attendant laryngeal complaint, because larynx always has got major three functions. So whether it is dysphagia or whatever it is, you always ask for the other two conditions. Is there any problem with the voice? Is there any problem with breathing? Voice. Is there any change in the voice? Yeah, say that it's not a major obvious complaint, and no breathing difficulty, no breathing difficulty. So that's generally that kind of history is good enough. But suppose this is only 10 days, so it's not an important issue. Suppose somebody comes, say that for 6 months I am having this complaint. Okay, then you should add another very important question: are you losing weight? Because many times it will actually differentiate, help you to differentiate between a continuous simple globus case from a more sinister pathology. If somebody is losing weight, then even if it is a mild complaint, say something in the throat, you should actually take it very, very seriously. Now it is only 10 days, so not much history about whether there is any problem. Then of course you have to take all other major history. Are you on any medication? He is not otherwise healthy. He is not on any medication, allergic. And always ask, in swallowing, a vast majority of the swallowing patients, they will have reflux problems. So ask him whether history of any he doesn't have anything. So he doesn't have any major complaint regarding the reflux or anything like that. Are you a smoker? Smoking? Drinks? Nothing. So essentially that is a major history you need to take in a swallowing disorder. Okay? That's it. Any other clarification up to this point? I'm now just going to do the clinical evaluation. Anything else? Any other question you want to know, or any other thing you are fairly clear about how you should go about a swallowing disorder patient? Now, mind you, this is not a major swallowing case. The vast majority of the swallowing patients will come either from the neurology department or from the head and neck cancer surgery department. So 80% of the swallowing problem will be actually divided between the head and neck cancer surgery and the neurological cases. So they will be sending you patients with either with a Ray's tube or a gastrostomy and say that kindly advise whether this patient can be started on Ray's tube or on oral feed, and whether we can actually remove the gastrostomy tube. That's the question. So this is how you will essentially go on how you should evaluate. So you should have a proper very history, and of course he doesn't have any other major issue. But if it is a neurological injury case, if it is a head and neck cancer case, it is very important that you take detailed history. You should understand what you are dealing with. For example, a patient with a brainstem stroke will have major swallowing problem, because 9, 10, 11 cranial nerves are in the lateral medulla and 12th cranial nerve is in the medial medulla. So medullary stroke will have a lot of problem. Pontine stroke will have again problem, because it has got 5th and 7th cranial nerve, which are very important in elevating the larynx. Hyoid is actually elevated by the mylohyoid, digastric and stylohyoid. They are supplied by the 5th and 7th cranial nerve. So if there is a pontine stroke, patient will have swallowing problem. If patient has got a medullary stroke, again patient will have a swallowing problem. Lateral medullary syndrome is more problematic than medial medullary syndrome, because medial medulla has got only hypoglossal. Lateral medulla has got 9, 10, 11. So what is the neuropathology you should always understand. Then only you will understand. You should know what you are looking for. And sometimes you get a patient who has got a middle cerebral artery stroke. The neurologist or the physician will tell them this patient has got an MCA stroke. Patient is not swallowing, kindly advise. MCA stroke as such will not have any problem with the swallowing mechanism. Still, they won't swallow. What is the problem? That's a cortical level problem. So in an MCA stroke, if you put food in the mouth, he will simply keep the food in the mouth. You won't swallow. Because it is due to two conditions. One is known as a swallowing apraxia. Second is known as a swallowing agnosia. Both can occur. Swallowing apraxia means patient doesn't know that the food in the mouth is for swallowing. It looks so trivial and simple, but in a middle cerebral artery stroke, patient will have this condition. They will not swallow. So they will just keep the thing in the mouth. That's known as the swallowing apraxia. And there is something known as swallowing agnosia, where patient simply doesn't understand the food is in the mouth. Right, you keep the food in the mouth, but there is no sensation in the cortical level. So patient doesn't know that the food is there. So both these conditions, their brainstem is perfect. So they are not going to aspirate, they are safe candidates. So you can actually tell them that, you can tell the bystanders say that this is okay, patient might improve. There is no harm in discharging this patient and sending them home, saying that you can actually try giving a lot of food. Because even if he attempt to swallow, nothing will happen. But on the contrary, if it is a brainstem stroke, you shouldn't advise that, because they can aspirate and die. So in a brainstem stroke where there is a lot of nucleus is involved, chance of patient developing aspiration is very high. So there you have to do the swallowing therapy or swallowing rehabilitation under supervision. While in a middle cerebral, in a cortical stroke, nothing is going to happen. Patient may not swallow, that is altogether a different issue. But even if he attempts swallow, nothing is going to happen. Okay, so then you can actually send them home. That is very important. So that is how you should take always history. And regarding the head and neck cancer, you should understand which all surgeries are more troublesome than the other conditions. For example, you can take the entire half of the mandible, nothing will happen. Most patients will have only a cosmetic problem, they will swallow. But the moment you cut the symphysis mentae, this part, swallowing is gone. Because that's a major issue, what is known as the hyomandibular complex. From the mandible, the mylohyoid to the hyoid is so important in swallowing. In elevation, I told earlier that one of the key movement in swallowing is the elevation of the larynx. Only when the larynx elevates, it comes underneath the protection of the tongue base. And only when the tongue elevates, the larynx elevates, cricopharynx is opened up. Because cricopharynx to open up, it needs stretching. And stretching is brought about by the elevation. So if a patient has undergone symphysis mentae resection, even if it is a very small tumor, patient will have significant swallowing problem. So this is how in neurology and head and neck cancer, you should understand what is the pathophysiology of swallowing. There are a lot of other conditions. Because of the time constraint, I cannot go into that. Say for example, again, if there is a floor of mouth surgery, floor of mouth has been removed, what will happen? The tongue will get adherent. So what will happen? The propulsion of the tongue will not be great. So lot of these conditions, you should understand what is the problem, what are the conditions. So pathophysiology, how you should always check for. Okay, now the next is the clinical examination. Basically, you do a standard ENT examination, especially the cranial nerve. You should look. I'm not going to do all those things. You do, especially the 5th nerve, 7th nerve, 9th nerve, 10th nerve, 11th and 12th. You look for any weakness. Okay. And now, always ask him to watch. Ask him to swallow. Ask him to swallow. Okay, you can see that. You see that the larynx slipped under my swallowing. You can see that. So that means laryngeal elevation is normal. That's very important. And always look for laryngeal crepitness. You know what is laryngeal crepitness? Laryngeal crepitness is actually the cricoid, not the thyroid. Cricoid moving over the vertebral column. So look for any abnormality there. It is present, especially in a female. You should look also in male. You look for the pallor and the koilonychia, because there is no chance of any Plummer-Vinson syndrome. So always care. Now give me a little bit of water. Now, ask him to drink. Watching the act of swallowing is very, very important. It many times gives lot of clues. It also gives, not in his case, not in patient who has got lot of swallowing problem. It might also teach you how you should treat them, because many times patients themselves will develop a wonderful compensatory mechanism. So they are going to teach you, how I am going to swallow. So how your swallowing therapy is going to be planned many times depends on the way patient swallow. So always start the clinical evaluation after the ENT and the neurological examination. Always ask the patient to swallow and watch it. Okay, right? Just swallow. Essentially, that's normal. Of course, we don't expect anything abnormal in him. So he is swallowed normally. But many times, again, we don't have a lot of time, but we'll just few things. It's a good practice to auscultate over the neck, right? And whenever you get time, you auscultate over your neck when you swallow. There's a classical sound. How the swallowing produces sound. There is a swallowing sound, always in normal people. Suppose there is narrowing, you will really say very high pitch sound. It's like stridor, you know. When the air goes through a narrow segment, you get here stridor. Similarly, when the foot go through a very, very narrow segment, you get a real high-pitched squirting sound. So always learn to auscultate neck when the patient swallows. And next is that many times, again that history may be there, some days patients say that, you know, our patient will cough immediately taking the food. Yes? Okay. So suppose patient is coughing. Suppose the patient is coughing after food intake. What does that suggest? No. You can get two kind of cough. That's very important. Timing. Patient cough immediately after taking food, or patient cough little later, maybe 30 seconds later, 1 minute later. It gives to an idea about two conditions. There are actually two conditions. Suppose it is a laryngeal incompetence, like vocal cord is not closing completely. What will happen? Food will go to the moment he swallows, it will go to the larynx, patient will immediately cough out. So that suggests laryngeal incompetence. Suppose patient has got a pharyngeal incompetence. You saw earlier in the video, the right side there was a paralysis as well as there was pooling in the saliva. Suppose the larynx is competent, what will happen? Patient will swallow saliva, but there will be some food in the pyrethrofossa, right? And you know that during swallow, respiration is abolished. It is apnea. After a few seconds, larynx will open up because naturally patient has to breathe. So whatever food was there in the pyrethrofossa will go to the larynx. So patient will have a delayed cough. So if patient has an immediate cough, it suggests laryngeal incompetence. If patient has got a delayed cough, it suggests pharyngeal incompetence. Okay, you can have both actually existing together, but that's a very valid clue. Just like, you know, about that solid and liquid. You know, solid is means if patient has got more problem for the solid, it is a narrowing. If patient has got more problem with the liquid, that is a neurological problem. So all these things that can actually teach you a lot of things. Always watch whether there is a cough, and if at all cough is there, also look whether the cough is efficient. Some people will have cough, but they won't be efficient. We'll come to that. So that is this much. Now, with this much of investigation, we will actually now go for the. So I'm just going to spray with Silocan, just one puff, telling the number. This is slightly stinging for a minute. After that, you'll be okay. Okay. So I'm just going to spray a little bit. That's all. You just spray one. I hope it is that low is okay. If that is not very patent, then I might spray here also. Some people will even tolerate even without any things. Make him sit facing so that I can.
No, I have no phone. Yeah.
So where is the screen coming? No. How will the audience? They will be seeing. So switch on. So again, so this is anybody who came little late. This is the transnasal esophagoscope marketed by the Pentax company here. 45 centimeter long. It has got 4.2 centimeter diameter. It has got an only one dimensional movement. The side you have to do it here. There is a lock here. Once you want to fix it, you can actually lock it. Then the movement of the knob will be. It is possible, but it is far more tighter. But when you are doing it, unlock it. And there are two buttons. This is a suction. That is unfortunately not here today. This is the air blast, switch on the air blast. So that is to keep the esophagus open. Is it open now? Let me see. Yeah, it's there. So this is to for the green button is for the air insufflation, and the yellow button is for the suction. Okay, right. And of course, if you want, you can actually put there is an instrument channel. You can do it. That's it. Can you white balance it? The light is not on. Light is not on. Yeah, power. Increase the power. That is very weak light. Go. Yeah. Now white balance. White balance. No, that is color. Is it white balance? Okay. Okay, we'll just try it now. Water so that we can tell him that I'm going to pass through the nasal cavity. It will not pain. Just ask him. So I'm going along the floor now. Ask him to breathe through the mouth. Through the mouth. Now, first I have reached the neck. Now ask him to breathe through the nose. Breathe through the nose. So I am just going down there. You can see the epiglottis there. This is the position. This is the place at which you should do the FEES. Flexible endoscopic evaluation of the swallowing. You can see that I am at the, I think there is some problem with the focusing. It's actually very sharp scope. I don't know, maybe there is some problem with their adjustment. Okay, anyway, you can see that. Ask him to say E boliye. You can see both. Can you increase the light? Light is. Yeah. Okay. Now, and ask him to protrude the tongue now. So you can just watch the vallecula, everything is okay. You can see both vallecula, there is no pulling. Now you can put his tongue back. Now, you heard that ideally we should be doing a colored thing, but since there is no colored, we are going just be into water. And before that, ask him to swallow. Swallow and watch for the white out face. Did you see that? That's a white out face. For a split second, you don't see the larynx. That's key. If basically you are seeing the larynx throughout the face, there is something seriously wrong with the swallowing. Okay. So you swallow once again. Yeah, you can see that.
But for that, the spoke tip has to be right there. If it goes down, then probably it will
touch and irritate. Yeah, that's it. It has to be a bedside. You have to be at the level of the just above the epiglottis. This is the correct position for swallowing. Okay. Okay. Now, give him some water. Just don't swallow now. Ask him to keep in the mouth only when we tell they should swallow. You should try actually both swallowed and liquid. Now, no, he swallowed. You shouldn't have swallowed it. Okay, give a little bit. Why you are telling that is that? Swallow again. Okay. Swallow once again. Yeah, why I'm telling that, why you should do that? Because in tongue dysfunction, there is what is known as the premature swallow, premature spillage. So a normal person should be able to keep the food in the mouth. But if there is a tongue dysfunction, even without them planning to swallow, food will go down. So always watch for premature spillage and then only ask the patient to swallow. Swallow. Okay. Yeah, now you can see that is epiglottis. Now, suppose you are going to do transnasal esophagoscopy, what you should do, that is what I am going to now show you. Of course, we don't have the suction, so that's a little bit of a thing. Now, you shouldn't go and try to force your scope down to the esophagus. No patient is going to tolerate that. So you should weight the esophagus to telescope over your scope. So what you should do is, you should go into any of the pyriform fossa. Don't go to the post-cricoid region here. That's a very sensitive area. Go any of the pyriform fossa. There, somewhere there. Go there. And ask him to swallow. You can also, there is a very good technique when you are doing the transnasal esophagoscopy. Ask him to pull down. Not doing it. One thing is that you ask him to drink or sip lot of aerated water, like 7-Up or Sprite. What you do is then give a straw and then ask him to drink. So it will not only open up the cricopharynx because of the aerated content, that the esophagus will be kept open. So that's a very good technique. It's not a must. So I'm just going to try to whether I can do the scoping here only. So just go to the pyriform fossa. Now ask him to swallow again. Swallow again. See that? I've entered the esophagus. Can you see that? See, I am pumping in lot of air. So patient may have a little bit of difficulty, but there is no suction. That is the only problem now. See, you can see that when I am pumping in air, you can see the esophagus is opening up. Yes. And see that? Pull out. Keep on swallowing. See that esophagus? Yes. I am going down. Okay. Okay. See, that's a lower esophageal sphincter. You can see that? That's a lower esophageal sphincter there. See that I have reached stomach. Can you see that? See, that's the stomach, the ruler. Can you see that? Yes. Right. Now, when you look for, just keep on, if suction would have, you can see that is the lower esophageal sphincter. Look for any barrett esophagus or any amount of esophageal erosion. Look for, keep on. Now, when you pump in lot of air in the lower esophageal sphincter, patient get lot of belching sensation. So you should actually apply suction here. But now I am coming back. Since it is normal, I am just trying to come out quickly. I don't want to make him uncomfortable with that. So you can actually take again on coming back also. You keep on insufflating and then take out. So it's actually a very quick procedure. Sorry. And if suction is there, it won't be that discomforting because you can actually suck out all the air and after insufflating it. So the good thing here is that you are actually seeing not only the pharyngeal stage but the esophageal stage. And this is a very fascinating equipment. Actually, it gives, there is some magnification, but it gives, it will be okay. And telling that that belching symptom will go away. I cannot express it in Hindi. Just somebody tell him that it is okay. It will be okay in a few minutes. He has got, usually we give a little bit of gelusil MPS after that because that air sensation is there. So no sedation required. Okay, we can see. So just get it cleaned up. Just clean it up. Clean it. Yeah. So bring. So we have got one more patient, but any clarification required from this case? Yeah, please.
Sir, I am Dr. Priyanshu. Sir, how can we see the esophageal face while insufflating the esophagus.
How can you see?
Sir, we want to see the esophagus stage using this scope. So how can we even see actual swallowing while insufflating it and while being in it? Because that will already modify the how it is being swallowed.
So what you do is you give both colored fluid and semi-solid, right? And you don't continuously keep the insufflation. You actually do it intermittent and keep on seeing that. What you are going to look is mainly if there is a structural lesion, and if the normal peristalsis is there, it will be cleared in 10 seconds. Right, at the end of 10 seconds, it is still there. There is a segment, there is a problem. That means that peristalsis is not functioning. There is an incoordinate peristalsis. Of course, patient has to swallow. Just like in that whiteout phase, you don't see anything in the larynx, but you still know that the larynx is normal or not. You know whether patient has got aspiration. Exactly at the time of swallow, you won't be able to see that. Similarly, when the peristalsis happen, in between you have to insufflate and go on seeing that. So what you are looking is that in 10 seconds, does it clear? Is there a structural problem? And is there a functional segment where there is no peristalsis, there is megaesophagus, where there is food is stagnated there? These are the things you are going to look. And also you are going to look whether there is any hiatus hernia that is coming back.
Sir, can we get symptom of early satiety in these patients? I have observed some patients complaining that they get fullness of the stomach. Means problem in swallowing also, along with they say there is fullness even with the small meals they say.
Yeah, that may be, but that is more probably in the realm of gastroenterologists than in our field. What we are going to look is actually only into the esophagus, not into the stomach.
Yes. We
We can actually have look into the stomach, but generally we don't treat that, you know.
So when picking the pyrethrum part, we have to insufflate so that the esophagus.
No. At pyrethrum fossa, you need not insufflate anything. You just go and be near the pyrethrum fossa apex. Then ask the patient to swallow. Either he can do a dry swallow, or even better is that keep aerated drink so that he keep on swallowing. The moment swallow, what will happen? You see that the larynx elevate, and that scope is there. So what will happen when the patient swallow? The pharynx comes and telescope with your scope. So you shouldn't put the scope into the esophagus. Esophagus should come in. Once you are inside the esophagus, keep on insufflating. That's the key. If you force, patient will retch and violently retch. You know, you shouldn't do that.
Sir, one more theory, sir. So can this procedure be converted into forehand? Means someone will insert it and someone will handle this.
When you are doing a procedure, a therapeutic procedure, you need that. You need assistant. Otherwise, you can do it alone, right? You can do it.
And sir, during inserting, we need to straighten this cord, or we can bend this. There is no problem.
Which one?
Sir, during doing the procedure, it's diagnostic only. So we need to. So what should be the position of our scope and the cord?
This is the standard. There are many methods, but this is the common method. You hold like that, and with this you control. There is a fishing rod technique also, which I don't use that. Instead of keeping like that, keep like that. Now, suction is on. That is air. This is the suction.